my commission here is to talk about the procedure itself. There are many ways to do this procedure. There are as many ways to do this procedure as there are people doing this procedure. And they all have logic and rationale for what they do. And some of it's very good logic, some of it's not so good. I don't propose to show the right way to do this procedure. I basically show the way I do the procedure. I think there are many ways to address this issue, some better than others, but I don't want to make those judgments or comparisons. I had the procedure and the procedure's been done differently. I'm not casting any aspersions or criticisms on anybody else's techniques, but I'll try to explain my own logic and see how you do with that. I have no financial disclosures to make. The indications for the procedure are in flux. It seems to me that many of the symptoms that we see in patients with multiple sclerosis are symptoms that we see in other diseases associated with venous obstructions. So we see venous obstructions, for example, in patients who are on hemodialysis perhaps because they also develop pathology of their jugular veins, and they do become somnolent, fatigued, confused. So perhaps we need to look at this procedure as one to treat symptoms rather than a disease. Because after all, multiple sclerosis in general is a disease of exclusion rather than a disease that's clear-cut diagnosis. So among the symptoms for liberation would be chronic fatigue, confusion, inattentiveness, lack of concentration, headaches, loss of balance, venous congestion of the optic nerve, and tinnitus, especially when it's pulsating tinnitus, which is often a sign of obstructions or abnormal flow within the jugular vein as it passes through the petrous bone, where the ossicles reverberate and from which one gets sound. Many patients with multiple sclerosis have tinnitus. Many people in the general population have tinnitus. But the tinnitus that I'm talking about is very specific. We're not talking about the high-pitched whining sounds or the rumble sounds. We're talking about the whoosh, whoosh. That's a venous sound as it emanates and traverses the petrous bone. Another indication would be to fulfill 2 of the 4 established criteria for CCSVI as agreed upon and soon to be published by the International Society of Neurovascular Disease. I'm not going to get into that. There are other people who will talk about that. There were 5. There are now 4 that are established. Some people are still using the 5th one as a measure. Perivenous inflammatory plaques suggests venous pathology. That's been established for about 150 years. And unexplained demyelinization, that is demyelinating disease without a clear-cut diagnosis. That's not to say that people who have demyelinating disease with a clear-cut diagnosis can't also get inflammation or have abnormalities of their jugular veins. It's just that in general, somebody with Lyme's disease, for example, would have a demyelinating disease of clear-cut diagnosis, and by itself would not be an indication, in my view, to perform a venogram. Now, the goals of the liberation procedure are to interrogate the critical vessels that drain the brain and the spine. that is the internal jugular veins and the azygous vein. Generally, people don't image the vertebral veins directly. Not sure why. I think that perhaps next year that's a frontier that we'll explore. But at this time, those veins are a bit more challenging to address. And it seems like the pathology is more located in the internal jugular veins. In addition to those three major veins, there are other veins that are contributing to the body of fluid that is the cerebrospinal venous circulation. They include the renal vein, the iliac vein, the ascending lumbar vein. These veins don't cause CCSVI, but if those veins are also involved in obstructions, the collateral blood flow of those veins adds to the already overwhelmed circulation that's drained by the jugular veins, the vertebral veins, and the azygous vein. As an example, the renal vein has a blood flow of about 500 milliliters a minute. Each side of the brain, if you could divide it in half, has 375 milliliters per minute. So the kidney has more blood flow than the brain. If the outflow from the renal vein is obstructed, that blood's got to get out of the kidney. And it has a few ways it can get around. But one of them is a clear-cut, in some patients, a clear-cut connection between the renal vein and the hemiazygous vein, which is then drains back into the azygous vein. So even a normal azygous vein, when encountering the potential for 100 or 200 milliliters of blood through that collateral, would overwhelm an otherwise normal azygous vein. If the vein is abnormal or obstructed, that excess is going to also contribute to the overwhelming of the system. Now, in addition to interrogating those vessels, we want to detect the sites of obstructions in any of those veins and try to understand what the pathology of the obstruction is. Because they're not all the same. The treatments are not all the same. Some have a better prognosis than others. Some are associated with more complicated problems after treatment than others. So we want to try to differentiate some of those causes of the obstructions. And finally, we want to relieve the obstructions to enhance the blood flow out of the brain. And of course, overriding all of that is to do no harm. That's always what we have to do. So I'm going to talk about the procedure. The patient at this point would be, have met the criteria for the procedure, would have already had a due diligence consultation, would have understood the risks, the benefits, the alternatives of the treatment, would have understood the postoperative care, and after all of that's done, that patient would make an informed consent to undergo the procedure. So the more detail you get in that consultation, the more informed you are about your procedure, and therefore you've done your own due diligence. Having done that in New York State, we are now required to do what's called a timeout. That's recommended by the Joint Commission of Accreditation of Hospitals, and that requires that the patient participate with every member of the group of the team that's going to do the procedure to assure that we have the right patient for the right procedure by the right doctor, and that everybody's on the same plane. So in our institution, the patient is gowned, prepped, and then everybody stops. All the instruments are laid out on the table. We agree on the instruments, and then we have a conversation in which the patient is introduced to every member of the team, and then the patient introduces themselves. The patient must verbalize why they're on the table and who's going to do the procedure before we can commence the procedure. Anything less than that is considered in New York State professional misconduct. And the purpose is to avoid having patients have the wrong procedure done, have the wrong leg removed, and all kinds of things that we know happen in medical care. Okay, so having done that, I wanted to just show you some of the instruments on the tray before we go. It's a relatively straightforward, simple procedure. When the procedure ends, the tray should look pretty similar to that. There shouldn't be a lot of blood all over the place. There sometimes is, but not. The instruments include a fluoroscope, an ultrasound unit, and a monitor for most operations. In my operation, we also include an intravascular ultrasound device as another technique. The ultrasound is used to evaluate the access. Which vein are we going to enter? Most people would enter the femoral vein. Most people would enter the right femoral vein. Some would enter the left femoral vein. The left femoral vein makes it easier to interrogate some of those branches that we talked about, like the iliac vein and the ascending lumbar vein on the left side, which continue on up into the hemiazygos, as opposed to the right side, which is a bit more difficult to do. I don't puncture the femoral vein. I puncture the saphenous vein. The saphenous vein is an accessory vein that drains into the femoral vein near the inguinal area. The reason that I use that vein is that it's less critical a vein than the femoral vein. Thrombosis of the femoral vein is theoretically a life-threatening problem that can lead to pulmonary embolism if there's thrombosis of the vein. If I puncture the saphenous vein, if it thromboses, it's not going to thrombose the femoral vein. We also know that many patients will have periodic procedures rather than a single procedure. So we don't want to repetitively puncture a critical vein like the superficial, the femoral vein, because that vein is draining your leg. So we don't want to traumatize that vein. So that's the logic for using a saphenous vein. Most people don't use the saphenous vein. The other instruments that we see are a fluoroscope that has ionizing radiation. It goes through the body. That radiation is attenuated as it goes through various tissues. And what comes out of the X-ray beam is received by that device at the top of it, the hood, and that receives the X-ray that's actually made it through the body, and that is then constructed into a image that we can use. The images that we see things that are opaque or lucent. Things that are opaque include bones, metal, stones. Things that are radiolucent are the lungs, the bowel air. We don't see the jugular veins or the azygos vein. What we see are the landmarks that allow us to know where those veins should be. And they're relatively reproducible. We know that the jugular vein is going to enter its parent vein right at the level of the clavicle on the medial side, so we know where to go to try to find that vein with our catheter. So we use fluoroscopy just to use the landmarks. If we add X-ray contrast media or X-ray dye, that is also visible on the fluoroscope. So we can use the dye to help us move our catheters, which are also opaque, through the body. Because we're not seeing the vein we're in, we just see this catheter going by the lumbar spine, and we know that it's near the kidney when it's at the second lumbar vertebra. But we don't see them directly. And we see everything on the monitor to the far right. And those monitors have a live image of the fluoroscopy in real time. And when we take pictures, those pictures are stored in a computer and can be reviewed periodically so that we can review what we're doing. We can move that reviewed image and move it to the second monitor, so we have a live monitor and a road map side by side, so we can use that to move things around in a safer manner. The fluoroscope is actuated by touching a foot pedal, so that's what you're seeing there. On the left is just for fluoroscopy, and on the right, where you see an eye and I don't know if you can tell, but that's a plus sign. That's a boosted image that allows enough X-ray to go through the body to get a sharp, clear image with the X-ray dye in it. And we end up with pictures like this, and we look at these real time, we store them, we can play them back over and over again to review things as we look at subtleties. The first thing we have to do is access the body, and I told you what vein I access, but whatever vein it is, the technique is relatively similar. It's called the Seldinger technique. Seldinger was a radiology resident who wrote his dissertation on access to the circulation without a cut down. Prior to the Seldinger technique, surgeons would open up the skin, spread the skin, find the blood vessels, put tape, loop, kind of like rubber bands around the vessels so that they could be pulled up and tightened to control any bleeding. And then under direct vision, a needle was either placed in the vein or artery, or a cut was made in the artery and a tube was put in. We've replaced that with the percutaneous technique so that the scars, if they do occur, are in an order of 2 to 3 millimeters in terms of a scar. That reduces blood loss, risk of infection. That's what Seldinger technique does. Healing is pretty much in a day or two. The whole principle of the access is to use a very small needle to enter and then sequentially dilate a needle hole rather than cut anything to make it bigger. So if you look at the bottom, you see the needle. The needle is really small needle, smaller than your average safety pin. It's hollow, and that's the hole that's made in the blood vessel and the skin. And then everything else that you see there are sequential dilators, tubes that go over the wire and stretch that hole. So there's no cutting to open things up. It's all sequential dilatation. And dilatation has rebound effect. When you remove the things that are in there, they recoil back to where they are because there's some elasticity to the tissue that's been stretched open. So the hole becomes smaller, and the amount of healing that needs to be done to bridge the hole is very minuscule. That's the logic behind it. So at the top you see a local anesthetic. That local anesthetic needle only goes under the skin. It doesn't go any deeper. And we give the local anesthetic, this case is lidocaine. You'll feel often a needle prick go in, a little stinging as the lidocaine starts to deaden the nerves. And then the skin and the tissue around the skin is numb. And the procedure is then done under that local anesthesia. Many physicians will put patients to sleep or give them strong tranquilization or drugs that make them have amnesia to the procedure. Other people will give an oral medication to relax patients. And most physicians would then give an analgesic, like a narcotic, for any painful components of the procedure. My practice is to avoid amnestics and tranquilizers because I think the optimum imaging is done with a patient partner who follows the instructions of holding breath appropriately, doesn't move their arms around while the procedure's going on, doesn't take their hand out of the through the petrous bone into the dural sinus, or when the balloons are inflated. Those narcotics that I use last 15 minutes, and then pretty much back to where you were, so that the recovery time is shorter. Okay. So the entry technique I've already described to you here, up to the last point. After we've dilated, we're going to put in a device called a introducer sheath. It's a big sheath. It's, well, in relative terms, it's big. It's a little more than 3 millimeters in diameter. So it's still small, but it's, you know, 1/8 of an inch. And that tube is about this long, and it goes from your leg into your inferior vena cava, which drains the lower half of your body, through the right atrium, which is where all that venous blood collects before it's pumped into the right ventricle and then pushed into your lungs. So because you can't get to the jugular veins without going through the heart, unless you were to puncture somewhere up above the heart. And puncturing above the heart doesn't give you the right shape and position of the catheters in order to do the work that you need to do. So you really have to go from the leg in most situations. So there's a moment when a guide wire has to go through the right atrium into the superior vena cava. And once that guide wire is in the superior vena cava, that long sheath is then advanced over the guide wire safely out above the heart. And then all the instrumentation is done without any risk of entering the heart. Because entering the heart with any of these things can lead to an arrhythmia of the heart. The heart doesn't like to be touched, especially the right atrium, doesn't like to be touched by catheters. It makes it fibrillate or have ectopic beats that are, you know, undesirable. So we want to get the sheath up, and then everything can proceed safely. It's an important concept. I don't think anybody should do the procedure without a long sheath. When I first started doing this, I didn't use a long sheath, and I did have somebody that went into atrial fibrillation and did require hospitalization. So it's unnecessary. Put the long sheath up there. You then don't have so many curves of the catheters. The catheters go straight up through the sheath, and that gives you more direction control of your instruments. So that's an important thing. So we give the lidocaine, we put the needle in, we get a little drip of blood out of that needle, we put a guide wire through that little needle, we put a dilator in, then we put a bigger wire, a dilator, and then we put that big sheath. This is the big sheath ending up. You can see it's really not that big. For me, that's big, but it's a long sheath. You can see it there, how long it is. And once we're in, you can see where we are above the heart. We don't have a pointer, but this is the azygos vein. That's the ascending azygos vein. That's the arch of the azygos. And the azygos enters the superior vena cava. And then the superior vena cava drains into the lower part, that's the atrium. So the sheath protects the heart. And then through that, we put directional catheters. There are as many shapes of catheters as there are blood vessels in the body. And each doctor has favorites that they use to catheterize different veins. There aren't too many catheters that can catheterize the jugular veins and the azygos vein ideally. But I have one catheter that I can reshape so that I can catheterize all the branches with one catheter. Now, in my technique, I catheterize both the right and left transverse sinuses, the right and left internal jugular veins, and the azygos vein. The addition of the dural sinuses for me is a relatively recent change. after coming into contact with a few patients in which the connection between the brain veins and the neck veins was the problem, not the neck veins by themselves. So it's great and wonderful to see the jugular veins, but if you don't assure yourself that the connection between the brain and the jugular vein is open, I don't think that you have really done a obsessive compulsive job. So I've added that piece. When I first started doing it, I had a technique that was what I would consider painful. I've modified the technique so that now the sensation that patients have is a stuffy feeling in the ear. Once the tube is in the dural sinus, we do 2 views of the dural sinus and then pull the catheter back into the jugular vein and then complete the study. So the time that the catheter is in the dural sinus is somewhere about a minute, and then we get it out of there because I don't want anything in the brain either. We do 1 view of the jugular veins, 1 of each view, and I do multiple views of the azygos vein because I can't get confident that I can see the azygos vein pathology no matter what I do. I think it's a different, more difficult view, a vessel to assess than the jugular veins, which are quite simple. Why? Firstly, if you have a cooperative patient, nobody's moving. The neck stays the same. There's very little movement of the jugular vein during the venogram. But in the azygos vein, the heart is constantly beating, and it causes some movement of the azygos vein during the imaging, and that leads to some degradation of that image. So it's more difficult to assess the azygos vein. So while I might do 1 view of the internal jugular vein, I might do 5 views of the azygos vein. Okay. When I do the imaging of the neck, I ask my patients, I tell my patients, take a deep breath in and blow it out, because that improves the outflow from the jugular vein. So I will not see veins that are underfilled. I'll get, hopefully, the best filling of the vein, so I don't have to anguish about whether some narrowing I see is simply because the vein was not filled from something that's a real stenosis. So I do it in expiration. If I do the azygos vein in expiration, I end up with total confusion because the patient's breathing isn't quite right and there's really degradation of imaging. So I always do the azygos vein in deep inspiration. Perhaps that's why I have never seen a candy wrapper stenosis. Because I think the candy wrapper stenosis is a phase of respiration, and it's not a real stenosis in most patients. So I encourage people to do inspiration imaging of the azygos vein because it's just a different animal. The other 3 veins that we look at, which are the renal vein, the ascending lumbar vein, and the iliac vein, are usually exit strategies. These are veins that are secondary. If we run into troubles, we've taken care of the real issues. These secondary issues we could look at another time. So I focus primarily on the main veins and do these other veins later. If I can do them at the same time, it adds about 10 minutes to the procedure, so it's not really time consuming. I do most of my injections by hand. Some people use power injectors. I find that power injectors cause too much flow and things look too bizarre. There's too much reflux that may be just simply the power injection overwhelming the normal flow and volume of the veins. I started with power injection and stopped. So I might do 1 injection that's a very gentle injection to get a sense of what the dye flow is like. And then I might give a more powerful injection to look very clearly at all the anatomy and get everything distended. We start with the dural sinuses. This is both the dural sinuses here. We see the transverse sinus, the sigmoid sinus going through the petrous bone, and then the jugular bulb, which is sitting in the petrous bone, and then below that is the jugular vein. It's not uncommon to see a small amount of narrowing right at that level in everybody. I don't treat that. I treated it. It doesn't stay open. You can balloon it. There's no deformity of the balloon. And it's simply a vein being pressed between a muscle and a bone. If I see collateral veins going around that area, then I have a different perspective, but I don't really pay that much attention to that. Then we do both internal jugular veins. Most of the abnormalities are in the valvular areas. The valves are stuck. They don't open fully. Sometimes they act like a funnel, and I'll show illustrations of that later when I show you IVUS images. The findings of abnormality include stasis, where the contrast media just sits in the vein and goes up and down and doesn't empty. Or you see tremendous collateral vessels surrounding and draining down into the chest because there is no good outflow from the jugular vein. Stenoses can be, I'm calling a stenosis anything that leads to a narrowed vein. The narrowed vein could be caused by congenital development, fibrosis, lack of volume, and many other causes. So part of the process is trying to differentiate between a real narrowing that's really a stenosis from some of the physiological narrowings that are not. I also want to look for duplications in which there's extra walls between inside the vein, or septums, which are the same thing, or membranes, which are more transverse narrowings. Membranes are like a wafer sitting across the diameter of the vein, and it resists flow coming down. They're very hard to see. And webs are more common in, these are like fibrous bands that extend throughout the lumen of the vein. They're commonly the result of maldevelopment of the adult venous system from the embryonic venous system. Our veins in the fetus decompose and then are restored as the adult version, and somewhere about the 20th week of gestation. And sometimes there's derangement in that conversion that leads to webs, abnormal valves, septums, and duplications. That's true malformations of the veins. The other thing that's very important is to recognize the pitfalls, which are things that look like abnormalities that aren't. And that's as challenging, maybe more challenging, than detecting the real abnormalities. For example, on that image of the left internal jugular vein, it's very obvious that there's narrowing of the lower part of the jugular vein down here. But if you look carefully, you see dye here and dye here. And between the two is the valve. And the valve's not open because we're getting, are you donating that? Yeah. Okay. So, good. Which button then? It's hidden in the middle of the tape? Oh, okay, good. Okay, so this is the vein. The rest of the wall of the vein is over here. The rest of this vein is not here. The rest of the vein comes out here. And what we're seeing is a funneling of the contrast media through this valvular gets below the obstruction, it washes back and opacifies the part below the valve. That's how you see the valve. So that's pretty obvious. It's the things that look like stenosis that aren't that are the real challenge. Now, if I can show you some reason why IVUS is so valuable. This is the intravascular ultrasound device. It goes over a very fine guide wire. It's about the same diameter as the catheter. But when it's in the area of the valve, you see these bright echoes in here, and you see the narrowing here. The wall is out here, where the valve is in here. So these are things that are much more subtle to see here, but on IVUS, and I'll show more later, I think it's much more interesting. So the pathologies that need angioplasty are real stenoses, not phasic narrowings that are underfilling. Stenosis of the valves, majority of the problem is stenosis of the valve. The valve just doesn't open, and it leads to a narrowing where the blood has to go through a narrowed segment before it reaches the rest of the vein. Have no illusion that your vein is obstructed and narrowed. The veins are not narrowed in most patients. The vein narrowing would be what developmental, congenital narrowing, which we call a hypoplasia, or something that would scar the wall of the vein. There's not much that scars the wall of the virgin vein that hasn't been punctured. So don't think that you have abnormal veins. Most of you don't have abnormal veins. You have abnormal valves. And that's a good thing, because I think the valve is more amenable to treatment than the vein itself. Then we have the hypoplasia, as I mentioned, the webs, septums, the annulus, which is a narrowing that's circumferential and pinpoint. That can be congenital. You can get that from a valve that's narrowed down or from a malformed valve that's elongated, and duplications in membrane. So these are the things to be treated. They all can be treated. Some are more effectively treated by balloon angioplasty. I don't have clarity about which ones need stents yet. Some of them probably need stents to maintain. Okay, so here is a balloon catheter. It's the same size as the diagnostic catheter, so to speak. It goes over the same guide wire, and it's crimped down so that you see a balloon that's welded to a catheter on both ends. Inside the main catheter, that's inside that balloon catheter, there's a hole in the wall of the catheter that allows you to put fluid through the catheter so that it doesn't come out the end hole of the catheter. It comes out into the catheter where the balloon is, and we inject the fluid into that port, and that's what causes the balloon to distend. We put contrast media in the balloon so we can see it distending, so that we know that we've got the balloon positioned in the correct location. And we know when the effectiveness of the balloon dilatation occurs, because at that point, the balloon conforms to its natural shape. Prior to opening the stenosis, the balloon is constricted where the stenosis is. I'll show you that. That's simple. This is the inflating device. This didn't work. It's not working. This is the inflation device. It's just a syringe that has a screw thread. We inject fluid from this thing through here into the port that inflates the balloon. That's this port. The fluid goes to the balloon, and the balloon starts to distend. We watch the pressure that we're generating, because at the beginning we do it by hand, and we're only strong enough to exert 1 or 2 atmospheres of pressure. Beyond that, we need some help. and that's what the screw threads are. You rotate the screw thread, and that puts more fluid into the balloon. And it puts that fluid in under pressure. So we monitor the pressure. Each of the balloons has a rating of pressure that it can tolerate before it bursts. So there's a nominal pressure when you can't inject it anymore and the balloon is fully inflated. There's a burst pressure that allows you to exert pressure against the resistance of the obstruction until you overcome that obstruction and break open the stenosis. And then there's more pressure that you can put in, which you sometimes can do, because they're rated for a certain pressure, but they usually can go higher. So sometimes we go higher than the rated pressure. There are low pressure balloons called compliant balloons, where they just inflate like a balloon. And then there are balloons that are non-compliant. They have a shape and they don't blow up into a round ball like a compliant balloon. They form a shape, and that shape is consistent. No matter how much fluid you put in, it stays in the same shape. Then there are low compliant balloons, and then no compliant balloons. The no compliant balloons have different pressure ratings. Most of the balloons that we use in our organization are high pressure balloons. Those balloons tolerate pressures as high as 18 or more atmospheres of pressure. To put that in perspective, 18 atmospheres of pressure is being underwater with somewhere around 600 or 700 feet of water on top of your head. It's a lot of pressure. The pressure is constrained by the balloon. The balloons are made of different materials that allow you to put a certain amount of pressure in. The longer and larger the balloon, the less pressure you can put in before it will burst. So balloon size, balloon length are both important in determining how much pressure you can put into a balloon. This is an example in that same patient. And if you see here, this is a high pressure balloon. You can see in the middle image a constriction. We call it an annular constriction. It's at this area somewhere over here. And that's the area of maximum resistance to opening. In general, that is the area of stenosis. So we dial up the pressure until that pressure effaces. That stenosis effaces. We believe when it's at that level here, if you've used the right balloon, you've broken the stenosis. Once that's done, some people hold this open, keep this pressure here for 2 or 3 minutes. I keep it for about 10 or 15 seconds. If I want to do it multiple times, I'd rather do that, but I don't like pressing on the vein for a long time. Then after that is inflated, we release the pressure. When we release the pressure, if there's still stenosis holding that, that we've just stretched but not broken, the narrowing will return. So if you release it, you might see some indentation again, and then you know that you've got to do another treatment or go to a bigger size balloon in order to completely open that stenosis. Now, the azygous vein is very different. As you know, it drains the spine drains through the vertebral plexus. The vertebral plexus goes into the intercostal veins. The intercostal veins go into the hemiazygous and azygous vein. So stenoses here contribute to an overall volume of blood within the spine. So if the native vein can't get out of the spine into the vertebral plexus and then make its way, it's going to find another route through the veins and lead to additional obstructions. Most commonly, what I find in the azygous vein is valvular stenosis. I find that the valvular stenosis is mostly not visible on venography. I can only see it with IVUS. There are other things that are even more difficult to see. They include webs, and webs are really difficult to see on venography, but can show up on IVUS. So many people will put balloons in the azygous vein simply based on the fact that there's reflux of contrast media away from the drainage, the normal drainage of the azygous vein. And they'll just routinely dilate the azygous vein. I don't do that, but a lot of people do that. I think that the azygous vein is actually more forgiving of balloon dilatation than the jugular veins. So perhaps there's merit in doing it, but I don't do that yet. These are azygous veins. There are two areas that are quite consistent in being real. The most common one is in the arch of the azygos, where there are valves here that may or may not be visible on venography. And then this area right below the arch of the azygos, there's often a narrowing right here, and I have a difficult time determining whether that's real or not. In this case, it was real, and we did balloon dilatation of this azygos. So we talked about why the left renal vein, so I'm not going to duplicate it, but these veins have a lot of flow. So if they're going to contribute to, if they're going to drain where the vertebral veins are supposed to be, I don't think that's particularly useful. So this is treated, I think of a picture, this is usually a compression syndrome. And in this case, it's the nutcracker syndrome, in which the central part of the renal vein is compressed between the aorta and the artery that drains your intestines. And it creates a nutcracker phenomenon in which flow is markedly inhibited here, and very often you'll see collateral veins going up to the hemiazygos and down into the gonadal vein, and a couple other veins as well. This is like the May-Turner syndrome, which is a compression of the iliac vein. That is also treated not by angioplasty, but by stenting, because these are compressions rather than fixed stenoses. You can put a balloon in there and inflate it really well, and everything looks totally great, but it's just going to get compressed again. So stents are what's necessary in those situations. Now I want to talk a little bit about complications. Everything has risk. Getting here put you all at risk. Listening to me puts you all at risk. But you choose to take risk because you believe that there's a greater benefit than a risk. And that's the judgments that you have to make based on giving an informed consent. So if you're not well informed, you can't give yourself a good consent to do this. Generally speaking, the risk-benefit is high because while not everybody benefits from the treatment, most people don't have complications either. So you have to balance complications against the benefit. The complications are numerous, and they're all either uncommon, what I would say is less than 1 in 100 patients, to rare, which is greater than 1 in 1,000 patients, or really rare, which is less than 1 in 100,000. Most of these complications are uncommon. Most of them are rare, some of them are uncommon. The uncommon ones are thrombosis of the vein after angioplasty, arrhythmia if you don't use a sheath, and transient hypotension, usually due to what we call a vasovagal response to puncture of a blood vessel, in which the heart rate goes down transiently. Blood pressure can go down with it. It's treated by fluids, sometimes with some medications to speed up the heart. And that's it. Occasionally somebody does get symptoms that become worse. Often that's worse but transient, some people just don't get better. Rarely does one get an exacerbation happening at that time, and it's one of the reasons that Mark may be right, that we should be doing venogram, MR venogram first, to see and MR to see the brain and see if the brain is problematic, whether there's any active lesions going on. But everything's pretty uncommon. Hemorrhage is very uncommon. The veins are under very low pressure. So even if they were to rupture, the compression necessary to stop the bleeding is gentle manual compression. Hemorrhage is more likely in a post-procedural time because of the anticoagulation that many doctors use for the treatment. So, just to summarize, we start with a local anesthesia needle and then work our way up from that access needle to balloons that can be even bigger than that one. They get deflated, they come out through that same needle hole that we made to begin with, and then the rest is up to you and nature.